Okay, hello everyone. Today I will present our recent work titled MMedAgent-RL, Optimizing Multi-Agent Collaboration for Multimodal Medical Reasoning. This is a collaboration work between UNC, Microsoft Research, CMU, and Yale. So this work explores how reinforcement learning can enable adaptive and dynamic collaboration among medical AI agents, ultimately improving multimodal diagnostic reasoning. So medical large vision language model, or LVLMs, are becoming increasingly powerful for diagnostic tasks. However, single agent models struggle when it comes to covering different medical specialities such as radiology, pathology, or oncology. For example, it is shown on the left. And recent approaches introduced multi-agent collaboration frameworks that mimic real clinical workflows. For example, a general practitioner triages the patient, and then specialists give up opinions, and then another general practitioner will give a final decision. But these systems rely on static pipelines, which cannot flexibly adapt to noisy or conflicting specialist opinions. So the key question here is, how can we design a multi-agent framework that dynamically optimizes collaboration for medical reasoning? So on the right, it's the teaser figure of their paper. It shows that their methods can reach the best performance on five benchmark medical VQA datasets, superior to those single and multi-agent baselines. Now let's look at some related work. First are some recent medical large VLMs, such as LavaMed, GPT Vision, and RedFM. And also there are already some multi-agent systems like MedAgents, MD-Agents, which we also covered in the previous group meeting. And currently there are also many reinforcement learning work for reasoning, start from DeepSeek R1 to the medical version like EUREKA. However, there is some gaps between the recent work and current situations that RL has not been applied to optimize medical multi-agent collaboration systems. Before introducing their method, I will also talk about some preliminaries. First are still the medical LVLMs. Currently, people have already integrating vision and language model for multimodal reasoning. And there are already some multi-agent frameworks which simulate hospital workflow. For example, like this. This paper mimic a whole hospital workflow, including receive a patient information and then send it to the corresponding specialist and then get a final conclusion. And also reinforcement learning, particularly GRPO, provides some optimized decision making without a critical model. And currently, another hot topic is curriculum learning, which can train a model step by step, from easy to hard, and this will increase the generalizability of the model. Here is the big picture of the MMedAgent-RL. So it is basically it is a RL-driven multi-agent system. It simulates real clinical workflow, including first, there is a triage doctor which can assign specialty for the patient. And second, the specialist doctors give some conclusion or diagnosis based on the patient's situation, and then they will perform independently. And third, another attending physician will integrate the knowledge from the specialist doctors and then drive a final conclusion. So the key innovation of this pipeline is the curricular multi-agent-RL they proposed. For example, here, one question or one patient come to the hospital, and then it will go to see the triage doctor first, and then it will send the patient to the special medical department, like the radiology, pathology, etc. And then the specialist doctors will give conclusions based on the patient situation. And finally, another attending physician will drive a conclusion based on the output of the specialist. And they use the curriculum reinforcement learning to optimize this multi-agent pipeline to get better performance. Now let's look at them in details. So the first step is the triage doctor. In real world, the first critical step when a patient visits the hospital is triage. Like for example, if we go to the hospital, we will be sent to specific department. So this step, the objective of this step is to assign patients to correct medical specialty based on modality. And it is called the triage doctor, which is also GP1. The base model is Quinn 2.5 VL. In this work, they have 7 candidate specialists, including pathologist, radiologist, surgeon, oncologist, and this another 3 departments. And they want to use this kind of specialist as the training labels from the dataset modality to train the model to get better performance. For example, here are some examples. Like if the model receive pathology slides, they will be referred to pathologist, and if they get chest X-rays, they will be referred to radiologist. And this is the policy of this agent. So which want to get the best specialist based on the incoming patient or the question. And they use reinforcement learning, specifically GRPO, to optimize the model. They also use the reward, including the format reward and accuracy reward, the same as DeepSeek, to optimize this agent. After they get better triage doctors, they will do the specialist consultation. The objective at this stage is they want to provide independent expert opinions, and they want to facilitate decision making for the attending physician. And this step is accomplished by the specialist model, such as GPT-4o or Huato GPT Vision. And this is the policy of this model. So this agent is not trained; it just do inference. But they will have several specialists at one time. So they will give multiple output based on the question. So the design choice of this step is every specialist, they act independently, and there is no majority voting like in the previous multi-agent system. They only give separate answers. And this step can avoid overshadowing minority, but correct options. So the final decision is left to the attending physician, which is the third agent. The most challenging part of this paper is how to build a good attending physician, which is a doctor to drive the final conclusion. The objective of this step is to summarize over the specialist output and also combine with this agent's own reasoning to get a final conclusion. And this agent must handle noisy and inconsistent specialist. For example, if they get less than 70% accuracy. And in this step, and here is the policy of this agent. And in this step, they constructed a curriculum multi-agent-RL algorithm, which to divide the questions into three categories, including the easy, medium, and hard. For the easy questions, they just imitate the specialist to make the final decision. And for the medium questions, they get a balance between themselves and the specialist answer. And for the hard questions, they override specialist, but reason by themselves independently. The training is also conducted by the GRPO, and it also used the rewards, including format and accuracy. Yeah, so this step want to get a stage-wise learning, prevents local optima, and improves alignment. Here shows the specific detailed algorithm of this curriculum-based multi-agent reinforcement learning. So the input, including the task dataset, here including the visual input, text input, and this Y is the sorry, this Y is the specialist label, and then they have policy model and group size, some inputs, like the previous GRPO algorithm, and they will first initialize the data set of easy, medium, and hard questions as empty data set, and during the inference of the previous two doctors, they will classify the they will classify the questions into three categories: easy, medium, and hard, based on the accuracy given by the specialist doctor. And then they will conduct the curriculum reinforcement learning over the questions. So here, the method they use to conduct curriculum learning is by controlling the KL coefficient in the GRPO loss. When it made easier, so from easy to hard, the KL divergence coefficient increased from the 1 minus from this number to this number. And they use the same loss as the original GRPO paper. So I will, since I assume all of students is familiar with GRPO, I will omit the details of the loss function here. To evaluate the framework, they propose 5 questions. First is, can MMedAgent-RL efficiently improve model performance compared to other LVLMs and the Quinn 2.5 VL-based baselines? And second is, how does MMedAgent-RL perform on out-of-distribution datasets? Third, does each proposed component contribute to performance gains? Fourth, which is the impact of choosing different models as specialist doctors? And final question is, does MMedAgent-RL truly enhance the model's capabilities across various specialist configurations? Based on these questions, they conduct experiment one by one. The base model of their pipeline is Quinn 2.5 VL, including 3B and 7B. And the benchmarks they use, including 5 benchmark datasets. So for in-domain dataset, they use radiology, and this lake is a general medical dataset, including three medical special domains. And PathVQA is a pathology-specific VQA dataset. And out of the main dataset, they use this to also contain many medical special domains. And metrics they use is the accuracy on the multiple choice VQA. Here, let's look at their main result first. So on the in-domain dataset, the average this method achieved is 32.7%, and on the out of distribution dataset, they achieve 67.7%. And they gain around 20% versus those supervised fine-tuning baselines. So in this table, the first sections are all a single model performance. So we can see that GPT-4o reaches the highest on both in-domain dataset and out-of-domain dataset. And for those multi-agent collaboration baselines, they compare two multi-agent systems and also the combination of the GPT and Qwen 2.5 VL. So here, it means the first the so here these four baselines, they don't have the triage doctor because they assume the previous baseline does not have the step of send the patient to the corresponding specialist. So they just omit the first doctor. They directly conduct the specialist and then the general practitioner, which is attending physician. Like they just conduct the specialist output and then conclude over the specialist output, but they don't have the first step. And they, from the table, we can see their method with the 7 billion, which is the highest performance compared to all of the baselines. And in the ablation studies, they compare three situations, which including remove the triage doctor and specialist and their curriculum multi-agent reinforcement learning part. So they have proven that the third part is the biggest has the biggest contribution to the performance. And they also conduct specialist analysis. So this is to change different models in the second step. They conduct they compare different number of specialists. For example, the number ranges from 1 to 3, and also they compare different combination of the specialist, including 2 GPT-4o model plus 1 Huatou GPT model, 2 GPT-4o model plus 1 Qwen 2.5 VL model, and 3 GPT-4o model. And the experimental results shows that when they use 3 specialists of GPT-4o model, this kind of specialist output reaches the best. And to answer the question about the performance by difficulty, they also conduct experiment. So this shows the use of curriculum learning can enable robust reasoning under noisy input, and their algorithm for their algorithm of curriculum learning for multi-agent with reinforcement learning can gain the best input, the largest input gain on the hard questions. They also show some case study. On the right, it shows 4 examples of the case study. So it can be seen after their reinforcement learning, the model can give both the process of reasoning about relevant medical knowledge based on the questions, and also the model will show how to get the summary or the conclusion based on the specialist output. So this is also a kind of aha moment in their reinforcement learning. For conclusion, this paper introduced a RL-driven adaptive multi-agent framework, and the curriculum learning strategy they use can benefit the noisy specialist, and they also can get human-like structured reasoning after using their curriculum learning-based multi-agent reinforcement learning. And the takeaways are first, dynamic multi-agent system is better than static pipelines of the multi-agent system. And this kind of RL can also increase the generalization across different domains in medicine. And this paper also introduce a pipeline that can make the multi-agent system towards human-aligned diagnostic AI. And that's all for today's presentation. Thanks for attention. Any questions?